Hey, good evening, everybody, and thanks for joining us. We're here to present Malocclusion Neglect, how ignoring orthodontic treatment jeopardizes your patient's oral health. My name is Dr. Ben Moralia, and I'm joined tonight by Cindy Sensabaugh. And right here you have our brief credentials. We're not going to spend too much time here. Certainly, most of you would recognize us as being in the oral health care part of dentistry, and we are, connected with obviously Cindy at Phillips and myself at Candid. So we'll keep it rolling here and get into what we're about to cover tonight, which is that with, 4 things, you can have really good oral health. And we're going to build you a nice puzzle on having a good bite, having home care, having hygiene visits, and having proper nutrition. These are 4 good principles and best practices for having a very healthy oral cavity. Now, as the oral health goes, the overall health goes, it's not a surprise, and those of us in dentistry are well aware, the mouth is connected to the body, right? How about that? Shocker. So with the mouth being connected to the body, the better your oral health is, the better your overall health is. And we're going to focus on these 4 items here to give you an idea that if we have a really good bite and some good home care and some proper hygiene visits and a good, nutrition as well for supporting us, we've got a nice foundation in place to have as healthy an oral cavity as we can for the duration of our life. And we are looking for that. That's very important to keep the oral health going for the entirety of our life. So when we talk about a good bite, loosely, I use those words good bite. And of course, the more formal way to talk about that would be malocclusion. So we could say a good bite versus a bad bite. And then we can have, the more formal words, we could say proper occlusion, healthy occlusion, good occlusion, and then bad bite, we can say malocclusion. So you know why we're using the interchangeable words, because on some level, we have to communicate with our patients. And so while we're today on a professional meeting, and as all professionals, we can use the words and handle the words malocclusion and good occlusion versus malocclusion. But when we're in the office, we don't use the word malocclusion. So crazy thing is, malocclusion is a word I usually am only using in a formal meeting like this, versus in the office, the word malocclusion never comes out of my mouth in the practice, because as we're talking to patients, it's much easier for them to understand the difference between a good bite and a bad bite. So when we're talking about these 2 things, we would love our patients to understand the importance of having their teeth be where they belong. So it's one thing to have all or most of your teeth in your mouth, and they can work to chew the food, but it's another level to have them placed exactly where they belong. So we teach our patients the difference between the good bite and a bad bite. And the way we do this is that we talk about the good bite being protective. So a good bite is protective. And what that means is that your teeth, your gums, and your bone have the chance to age appropriately when you have a good bite. And also with that, you have a good bite delivering a lifetime of proper function, excellent comfort, and also the beautiful aesthetics we'd like to see in our teeth. We think about a good bite as protective because it will deliver small changes over long periods of time, and we refer to this as healthy. So if we think about a good bite, all the teeth are where they belong, so they're lined up beautifully, but they connect appropriately too. So we'll call a good bite healthy because you have all of the teeth well aligned, you have them connecting appropriately, and what that delivers is a bite that can destroy all the food you want to eat over all the decades you want to do it. So you've got a bite that can destroy the food, but it's interesting, at the exact same time that your bite is destroying food, it is protecting itself. So the mouth, you could consider the mouth a very violent place when it comes to food, right? If you asked food, what is your opinion of the human mouth? It would say, it's really mean and bad and nasty and violent to me. So food takes a beating from the mouth. But when you have a good bite, the mouth doesn't hurt itself. A proper bite, teeth well aligned, connecting appropriately, it doesn't destroy the teeth, it doesn't destroy the gums, and it doesn't destroy the bone. So we think about the proper bite being able to do its job without hurting itself, kind of thing. All of these are ways to get words across to a patient so they understand that, yeah, I'm not just chewing my food because I can and there's no issue. If we have a good bite, it'll protect itself and the things inside, teeth, gums, and bone. But the bad bite is destructive. Now, a bad bite is destructive. We talk about the teeth, the gums, and the bone will age prematurely. So when we have a bad bite, the teeth, the gum, and the bone are at risk during the chewing. So while we can still do the chewing of the food, whether we have a good bite or a bad bite, we're going to get to chew the food. But the biggest difference is that the bad bite, where the teeth are crowded and out of place and then connecting inappropriately, when our teeth come together chewing the food with a bad bite, all of a sudden the teeth, the gums, the bone, they age prematurely because they're taking abuse when they're in the wrong spot. A bad bite can't protect the structures that are in the mouth from aging too rapidly or aging prematurely. And so all of a sudden you start talking about this as leading to or requiring more dental, periodontal, and endodontic procedures. Now, those are our fancy words, but requiring more fillings and crowns, gum work, and root canal work. That's how we might present to the patient. So we think about a bad bite as being destructive in that it will deliver bigger changes over shorter periods of time. So when we talk about a good bite is protective, well, we get to chew the food. It protects everything that's doing the work, the teeth, the gum, and the bone. A bad bite is destructive. The teeth, the gum, and the bone will suffer from wear and tear from being in this bad bite. And next thing you know, patients respond very well to understanding that there's a thing called aging, which we all have to do. Everybody is aging. But when you have a bad bite, your mouth is aging too rapidly. All of a sudden, it is deteriorating ahead of schedule. And no one likes to hear that their mouth is deteriorating or prematurely aging. And then, of course, it would lead into, well, what do I do to improve that? How can I improve that? So basically, we take a look at the difference between a good bite and a bad bite is that a bad bite will deliver changes that are bigger over shorter periods of time. And that's going to be with the teeth, the gum, and the bone. And that's what necessitates more dentistry, more periodontal procedures, more root canals. And all of a sudden, we have that issue of aging inappropriately. So we think about that pathway. And of course, malocclusion is our fancy word, but all of the things that would kind of show up in the malocclusion category. And now in this category where we have this list of things going on, of course, poor hygiene, we're going to get into that and cover that, but tooth wear, teeth shifting, tooth fracture, recession, abfraction, ortho relapse will lead you right back to a malocclusion, vertical bone loss, horizontal bone loss, restoration failures, muscle soreness, TMD, joint breakdown. All of the things related here, everything on the screen has a common kind of cause, and that would be in the category of having a malocclusion, a bad bite that is destructive. So the destructive that I talk about, or the premature aging, are all of the things we would see: the recession, the abfraction, the wear and tear, the chipping, and then of course bone loss, and then of course TMJ symptoms and or joint breakdown. So all of this is the culmination of having that bad bite and basically having all of the occlusal trauma delivering changes over time that are kind of quick. And next thing you know, you have a patient at an age where they still have decades to go, but the damage requires fixing it on some level. And then, of course, when we fix it, it looks amazing the day we put it in. But with malocclusions where the teeth are out of place and the bite is bad, it does take a toll on our restorations, and we tend to kind of lose them sooner. So all of a sudden, when we have a malocclusion or a bad bite, our mouth isn't functioning appropriately. Something is a little bit off. So whenever you're looking at crowded teeth and a malocclusion or bad bite, those teeth are going to work on each other. And so we have the teeth kind of beating each other up. We have fillings that break. We have teeth that break. We could see anything from wear and tear, incisal wear, dentinal wear, to abfractions, to broken and fractured fillings and teeth. Then, of course, we could see damaged or broken porcelain. Teeth like this, all of a sudden, well, we know that probably was cemented and had full porcelain all the way through with a contact point, and the piece has sheared right off of there. And you start thinking about, what broke that? And in the end, it really all should come back to my teeth and or restorative dentistry is probably wearing or failing or deteriorating or aging prematurely, thanks to the malocclusion that is underlying all of these different things that are results of occlusal trauma. So when we take a look at something like this, where we've got this little model here showing an occlusal traumatic position in the bite can deliver recession and abfraction. Today, that's almost common knowledge in the world of dentistry that having a poor bite can lead to recession and abfraction. And we would see, pictures like this where the patient has a fair amount of recession and abfraction here, but they don't necessarily have a rampant amount of plaque and bacteria. And so it's more likely that this level of recession came from a poor bite and occlusal trauma than it did from plaque and bacteria destroying the gums. And we can lose the gums from either pathway. We can have gum trouble like this from plaque and bacteria and poor hygiene. We could have it from a poor bite. It could be a combination of both. I look at pictures like this and I see probably the occlusal trauma, the poor bite, delivered most of the changes to the gum and the bone, and the plaque and bacteria I would put in like second place for causing this damage. And then the abfraction level is mostly related to the occlusal trauma and not necessarily a plaque or bacteria or toothbrush type of issue. So that gets us right along to our x-rays, where we start looking at x-rays and we find bone loss. And when we're seeing bone loss around the teeth, we can certainly have a list of things that can cause a level of bone loss. Gum and bone deterioration, loss, periodontal disease, gingivitis, all the words that we have. That level of change, it can occur thanks to plaque and bacteria. We're well aware that we have plaque and bacteria can cause bone loss, but we would want to have more than that on the list, because it's not just that. It's not just having plaque and bacteria causing bone loss and or the recession of the gums. We probably should be thinking about the bad bite as well. We might even start recognizing that the bad bite is a significant cause of the gum and bone loss. And it might be that you have a combination of both. You certainly will have patients where their hygiene is less than ideal. And of course, as we cover all the topics between hygiene and nutrition, you could have the perfect storm where everything is wrong. They have a poor bite, so we're going to get deterioration that way. And then we have the acceleration of all of this thanks to poor hygiene as well. And then if they don't come in for frequent dental visits and they have poor nutrition, this could really go south fast. But when we see x-rays like this where we have bone loss, we think, well, there's probably traumatic occlusion in here. And then we're going to work our patient through all of these things, getting a good bite, as well as then the other items. We're going to fill in that whole wheel for you. Some signs of occlusal trauma, we see them all the time. Enamel wear, enamel chipping. You can see the craze lines in the enamel everywhere. When you see that, you are looking at occlusal trauma. It is the results of having that bad bite be destructive and lead to that premature aging of the teeth. And we are looking to have our bite function in a manner that protects itself so that it can age appropriately. So, patients respond pretty well when they learn that their teeth and their gum and their bone, their mouth is deteriorating ahead of schedule or aging prematurely, and that there is a pathway to get them in place where they would have proper aging of the mouth, and it can equal the rest of them, not just the mouth going and accelerating into the old age faster. Then you have, views like this where, we've got multiple pictures just showing wear and tear over time. And wear and tear over time leads to more dentistry. So all of a sudden you get more dentistry. And when you get a filling or an inlay or an onlay or a crown or anything that's done in dentistry, chances are if the teeth are out of place and you have a bad bite, that we're very likely going to see our dentistry then suffer the consequences of the occlusal trauma, and we get to repeat it. And we know what that's like because we get the patient, and if we have them for a very long time, there's a pretty good chance we might track something over time, like a smaller filling, maybe graduating to a bigger filling. A bigger filling could graduate to a crack or then become a crown. A tooth with a crown might graduate to getting a root canal. Sometimes a tooth that has a crown gets a root canal in its future, but then gets a crack again, and it might be too much to restore that tooth. It becomes an implant. So we do have all levels in a general dental practice of seeing teeth kind of age prematurely, and it comes in the form of us churning over the dentistry maybe a little more often than we could if we had a beautiful bite. So when we think about the TMJ that shows up, well, when you have a bad bite and the teeth are kind of off and not connecting well, the bad bite usually has the entire system off. It's very difficult to have your teeth out of place in a poor bite and not have trouble with the musculature. And then, of course, everything related to the TMJ, including the condyle and disc, all of that is usually a little bit off. And then it becomes, what is the kind of response or sensitivity level of the patient? Some patients have a bad bite. Some patients have the bad bite, but they don't have a TMJ symptom list or TMD symptom list, and others do. The interesting thing in dentistry is you can't really practice in a general dental practice on any level without hearing about patients talking about or relaying their TMJ issues and their symptoms that they have with their jaw. And then over time, you recognize that, well, there's really two options. One is we treat it. We have options for them. The other option is we refer them to a TMJ expert or someone who wants to do that. As you're learning about your patient's, TMJ, you start putting all the pieces together. And if the bite is off, then the musculature is a little bit off. And if the musculature is a little bit off, the condyle could be a little bit off. And if the condyle is a little bit off, so is the disc. And if all of that is just a fraction out of place, it can produce symptoms. So it all starts with something off. And it's not unlike an analogy that you could think about if you had like a rock in your shoe. If you had a rock in your shoe and you were walking and you left it in your shoe, it might change how you walk and how you step. And if the rock in your shoe, normal walking steps would produce pain, you would shift your walk. If you didn't take the rock out, you would shift your walk and it would start to affect your ankle, your knee, or your hip. It basically throws that one little pebble in your shoe without removing it, could throw your entire walk off where you might feel it in your hip. So if you have your teeth out of position just a little bit, you might feel it in the jaw joint. And then, of course, it leads to people who go and take radiographs. And if you have imaging, you might start to show deterioration. And if we get to the point where we're seeing deterioration in the joint, then it's more advanced. This has gone on for way too long to be able to show this kind of trouble, because this kind of trouble kind of comes in much later. So you have an opportunity to help a patient earlier as opposed to waiting until this point where it gets a little more challenging.
Correcting malocclusion isn't just to make beautiful smiles. Not only can malocclusion negatively impact chewing, speaking, breathing, and one's psychological well-being, as you've probably witnessed, it can increase the risk of gingivitis, periodontal disease, and dental caries. When teeth are misaligned, they may be more difficult to clean. They're harder for us to clean, so of course, they're going to be more difficult for our patients. Early diagnosis of any type of abnormal tooth positioning can help direct treatment and therefore prevent gum diseases. The benefit of early orthodontic treatments include the improvement of access for dental hygiene or biofilm removal, occlusal balance restoration, adequate lip sealing, to name a few. And lip sealing is important because it protects teeth from the changes in pH balance associated with mouth breathing, which can increase your risk of caries. Compromised biofilm removal due to malocclusion increases a person's risk of periodontal diseases. If left untreated, the gravity of crowding and malocclusion increases with age, with a clinically notable increased severity of periodontal problems. Malpositioned teeth facilitate the accumulation of bacterial plaque by creating physical barriers to self-cleaning, which directly contributes to gingival inflammation. But with early diagnosis and treatment, you may be able to prevent bone loss associated with periodontitis resulting from malocclusion.
So we're going to dig into diagnostics. How do we look for, these patients and then kind of figure out what direction we're going in? And I much prefer to go after the root cause as opposed to the symptoms. So the teeth are kind of the symptoms, but the overall malocclusion they have can have a cause. And I like to focus on 3 different kind of pathways to look at as diagnostics. And I got to tell you, the advancing is not working for me all of a sudden again. So Nate, if you're in the background, yeah, this is okay. So for the diagnostics, the improper arch form is where we start. And we want to take a look at the arch form because an improper arch form leads to the occlusal trauma that we're talking about, doing all that damage ahead of schedule. So it's very common to look in a mouth and see a V-shaped arch or an omega-shaped arch. So if we're looking at a V-shaped arch or an omega-shaped arch, these are considered improper arch forms, and improper arch forms do deliver occlusal trauma. And then, of course, everything that the bad bite, being destructive, delivers. So we're looking for, Nate, I may have to ask you to do the slides. I don't have a control of the slide. So when we get to the difference between an improper arch form and a proper arch form, this is what a proper arch form looks like. So it's a beautiful shape. It has that beautiful, it's kind of like the Roman arch look because you are looking to have a broad, wide dome shape. This is a starting point for having perfect occlusion, is that you have a proper arch form, a beautiful Roman arch, so to speak, of the teeth. So if we see the V or the U or the V or the omega shape, we're looking to convert it to this so that we've got a proper arch form. That'll take us from unhealthy to healthy. Then, of course, when we get to our next slide, we're thinking about improper arch width. So let's take a look at the next slide and it'll show us where we're there. We can measure this. So the fantastic thing about improper arch width is that it can be measured. The transverse measurement is a diagnostic tool, and it is the shortest distance between teeth 3 and 14 measured at the gum line. And this was based on beautiful research out of the University of Michigan. Dr. James McNamara was doing growth and development research, tracking children as they grew and developed. And basically, he knew from all of his research that healthy, stable occlusions that develop naturally without any orthodontic intervention, basically all of the teeth going to place on their own, they had a 35 to 39 millimeter transverse measurement. And that happens to be the distance between 3 and 14. And the good news is you could measure it with a Bowley gauge if you happen to have a Bowley gauge at the office. And most offices have it. It's usually in the bottom of a drawer somewhere, stuck to the bottom of the drawer. You get a little spatula to free that up. But you can use a cotton roll. So we have pictured on the screen cotton rolls. It turns out the cotton rolls in your practice are 37 millimeters long. So if a cotton roll is 37 millimeters long, you can take it with the little tool, hold it between the teeth, and then you have a quick estimate as to where is my patient with their arch width, because if they measure between a 35 to 39, chances are that's a reasonable arch width. They have a reasonable occlusion. Obviously, when we're talking about crowded and poor bites, narrow is what you're going to see more of. So it turns out when you start to check the cotton roll between 3 and 14, very few people can fit it in, because most of the adults that you're looking at have crowded teeth with a bad bite, and they come in under 35. And you'll probably start looking at adults and recognizing that, ooh, there are some of them between 25 and 30. And it turns out the more narrow the arch is, the worse the occlusion is, and the more damage you'll find. Let's see our next slide. So when we think about a before and after, like a transition here, you could take these two pictures are obviously with clear aligner therapy, getting one to the other. So a before, the V or omega shaped arch, improper arch form, improper arch width, with clear aligner to develop proper arch form, proper arch width, and get into that range of 35 to 39. So obviously, if we recognize it, a poor arch form and a poor arch width, we're looking to address those two things to deliver a good occlusion. And then the next slide is going to add our third component in there, which we call improper buccolingual inclination. So see improper arch form, you probably have improper arch width, and you probably have improper buccolingual inclination. Now let's check this out, because it's a long list of fancy words. I'm very sorry about these long words on a Monday evening, but improper buccolingual inclination. It's a very simple concept. Bucco is cheek and lingual is tongue. It's a reference to the back teeth. How do the back teeth lean? Are our back teeth leaning towards the tongue, or are they upright and vertical? And these two pictures are just here to show you the difference in the view of proper versus improper buccolingual inclination. The left side of the screen, we have a patient whose back teeth are vertically positioned. So that patient on the left side happens to have proper arch form and proper arch width, but they also have proper buccolingual inclination. The back teeth are upright. And when the back teeth are upright, they can come together and deliver vertically loaded forces. And the mouth, the teeth were built to deliver vertically loaded forces. That's how it protects itself. On the right side of the screen, we're looking at the back teeth, and they are leaning in. With the back teeth leaning in, the lower teeth lean in, the upper teeth lean in. That lean delivers horizontally loaded forces on those teeth. So when a patient bites down to use the teeth on the right side of the screen, they can chew the food, and they might be able to chew the food just as good as the person on the left side. But the difference is on the right side of the screen, that mouth with the bad bite will be destroying itself in its chewing of the food. So we have occlusal trauma on the right with the improper buccolingual inclination. And the pathway, again, would be to upright all of the teeth and align all of the teeth to deliver a result that looks more like the left side of the screen. Let's see our next slide. Yep, so here it's a little pictorial. So improper arch form, improper arch width, and improper buccolingual inclination all deliver destructive horizontal forces to the teeth, gum, and bone, otherwise known as occlusal trauma. So our fancy words of occlusal trauma versus occlusal health is pictured here. And I pulled this from an old textbook of occlusion. It was circa 1970s. And basically it was doing all of the descriptions about the difference between horizontally loading the teeth versus axial or vertically loading the teeth, and that vertically loading a tooth will be healthy for your teeth, your gum, and your bone. But horizontal force, horizontally loading of the teeth will deliver occlusal trauma and will be bad for the teeth, the gum, and the bone. See that next slide. So a consideration, back to this slide when we're thinking about these two patients. On the left side, we recognize that patient has proper arch form, proper arch width, proper buccolingual inclination. On the right side, we recognize improper arch form, improper arch width, improper buccolingual inclination. But then I want you to consider what the GP does all day. A general dental office has a lot going on in there. So let's think about the general dentist and what their roles are. All of a sudden, they're doing fillings, inlays, onlays. Just go back one slide for a moment. The fillings, inlays, onlays, crowns, bridges, implants. You have restorative dentistry. You have also periodontal needs. So we have anything from hygiene and maintenance all the way to periodontal surgical procedures. Then we have the endodontic category, the root canal category, root canals, apicos, all that fun stuff. So in our restorative, perio, and or endo categories, in a general dental office, if you keep track of what you're doing when you have those patients come in to work on them, all of a sudden you would think about, hey, how many restorative, endo, or perio procedures are getting done on the patient on the left side of the screen that has proper arch form, proper arch width, proper inclination, versus how many restorative procedures, perio procedures, endo procedures get done on the patient that has improper arch form, improper arch width, improper inclination. Well, it turns out as you start keeping score, you'll recognize almost all of the work that we're doing as general dental practice gets done in the mouth on the right side of the screen where they have poor occlusion, because the occlusal trauma does deliver the changes that require us to fix it. Let's see that next slide to see what's walking through our office every day. And these are your everyday hygiene patients. These are just samples, examples of what might come in on a regular basis to a dental practice to be getting their regular routine hygiene care. And any one of these patients would come in and have a pathway to have gotten here. So they either had orthodontics as a teenager and maybe didn't wear their retainers and they've shifted to these positions, or they never had orthodontics and this is where they landed. But either way, we're talking about all of these are categorically like a mild type of malocclusion that any general dental practice could offer clear aligner therapy to deliver a better positioning of the teeth and a better bite, which is again protective and better for the teeth, gum, and bone going forward. So when you're thinking about what you see every day, there's a lot of opportunity for treatment, because even if you're a beginner in the clear aligner therapy space, most of the malocclusions you're going to look at are in the crowded deep bite category. And the crowded deep bite category we have on the left side here, which we call the less difficult. The less difficult clear aligner therapy cases are crowded and or deep bites. And then spacing is also less difficult. So when you're thinking about this upper left area of the screen, you've got crowding, spacing, deep bites. That's most or the majority of the malocclusions we would find. And overwhelmingly, it's the crowded deep bite. You have some spacing going on. And then on the other end, the far end, where open bites exist, cross bites and under bites like class 3, that fades to a little more difficult. So the good news is that the majority of the malocclusions are in the less difficult category. We have opportunities to help those patients. The minority of those tougher malocclusions exist, and that could be a referral for us. So in the GP practice, it doesn't mean we treat every single malocclusion that we meet. We think about this kind of grade here, and we can choose our comfort zone. And it doesn't mean as a GP you can't go after more challenging malocclusions. We just assume that you have had a level of orthodontic treatment to do it. So basically, your comfort level would put you in a space to be treating malocclusions. And the bottom line is that you have a lot of opportunity in the crowded deep bite, because those are less complicated and very easy to handle. Whereas underbite or class 3 type bites, open bites, and significant cross bites, that's a little more challenging. You don't need to treat those. You can refer those and or take proper amounts of education to treat them yourself. So good news is most patients you meet can be treated with your clear aligner techniques. Let's see the next slide. And so what does it come down to when you think about statistics? Well, the American Association of Orthodontists does have published papers that show 75%. So in looking at adults, it translates into 3 out of 4 patients that you see could benefit from clear aligner therapy. That means 3 out of 4 adults walking into your practice have their teeth out of position, have a bad bite, and have, of course, occlusal trauma going on with those. 3 out of 4, it's a generous percentage, but in my world, I would say it's higher. And of course, I'm not research, I'm in a private practice, but I see it more of a 9 out of 10 in my own practice. When we're taking a look at patients, how often does an adult come in, bite down, show you a set of teeth that really looks like a textbook type it on perfect occlusion? In my world, it's like 1 out of 10, not 1 out of 4. So we think about 75 to 90% of adults could benefit from clear aligner therapy. And then the next slide gives us our opportunity when we're talking to those patients, because a national survey showed what was at the top of the list for patients who were, choosing to have ortho treatment. And number 1 was cost, which of course, cost comes in at number 1 in almost everything, that people are concerned about the cost. And it was 73% were concerned about the cost. But look at number 2, convenience showed up at 70. And we'll get to the convenience being a significant opportunity when we do get to the monitoring section, because that's kind of where convenience comes into play. We have an opportunity there based on the monitoring. Let's see our next one. All right. So you might need an icebreaker. How do you talk to your patients? Well, you don't just, run at them and say, oh, your teeth are in the wrong spot. We got to make clear aligners. We got to get your clear aligners. You want clear aligners. You want your teeth straight. Like, you have to start asking questions and start a conversation. So the easiest icebreaker is, did you have braces as a teenager? So this has worked beautifully. I've been using this for almost 20 years. It's just part of the record and part of the history, and it gives you an opportunity to go forward. So we'll ask the patient, any chance that you had braces as a teenager? The good news is this is a yes or no question. And so as a yes or no question, if the patient says, yes, I did, then you follow with, because you know what you're looking at. If a patient had braces as a teenager and you're looking at crowded teeth and a bad bite, they didn't wear their retainer very well. So the patient who says, yes, I did, you can say, well, I had them too, and I lost my retainer about 3 months later, and my parents were done with that whole thing. So they said, nope, you're all done. And my teeth started to shift, and that was my pathway. How long did you wear your retainer for? And, when did you lose yours? And a lot of people have a funny story about that. And you'll have your answer. Yes, I had braces and I lost my retainer. And of course, when I stopped wearing my retainer, my teeth shifted. And we can say, yep, this is very common. When we don't wear the retainer, the teeth start shifting. And it's a slow and gradual shift, but the more your teeth get out of position, the worse your bite gets. And the worse your bites gets, all of a sudden we start noticing changes, because when we have a bad bite, it can actually be destructive to the teeth, the gum, and the bone. And then we're starting to see these things that would show up. As we look at the next slide, it leads us to what we're looking at. So we don't use a mirror. I don't like to give the patient a mirror and say, hey, do you see your tooth is wearing? There's, enamel missing. Take the good photos, because if you've got a large monitor plus your good photographs, then you're pointing to and showing them the things you're seeing from having that, bad bite. So all of a sudden you've got the large monitor, the good photos, patients get it. So the next slide is going to kind of lead us into our conversation. We're talking about active words, because these are things that are in progress and still going. So we say crowding. You have crowding, not your teeth are crowded. When we say your teeth are crowded, it kind of means like, okay, that's where they are. They're crowded. They're not moving. No, crowding is active, meaning they're still going. Your gums are receding. They haven't receded. They're receding. That's active and going. Your teeth are wearing. They're not worn. They're wearing. And this continues. They're chipping. They're not chipped. They're chipping. And the reason you're using the ing is because crowding, receding, wearing, chipping, it's all part of leading your patient to, you're witnessing these on the screen. They're seeing in a big photograph, crowding, receding, wearing, chipping. All of that is easily seen with your large monitor and your good photos. And as you're using those words, you're telling them that this is a progressive thing. These things get worse. The crowding will get worse. It's ongoing. So all of this that's happening, it's a slow deterioration that you're seeing. You don't see a daily basis change, but you have to combine it with their age. So a lot of this, as we're talking about the pictures and what we see, we relate it to how young the patient is. And it's relating to how young they are, no matter what their age. So whether your patient is in their 40s, their 50s, or their 60s or 70s, it doesn't matter their age. You're referencing what you're seeing, the damage, and all of the things that are happening And then you're comparing it to how many more decades they have to live and enjoy these teeth. So I like to go with the rough 95 years old. So I say, look, you're at the age of 60 right now, but I'm looking at your teeth and the wear and tear that's there based on this bite position. And we still have 35 more years. We have 3.5 decades to go. This isn't adding up to having these teeth remain healthy and your gums and your bone for this duration. So we should start thinking about doing something to improve the condition. So we take a look at the next slide. And we start talking about like this. And this is like a dead quote. And you can take this quote and kind of tweak it a little bit to maintain, your principles as well. But your oral health is very important to us. Surprise, your mouth is connected to your body. It turns out your oral health is related to your overall health. So the healthier your mouth is, the healthier you are. Our practice has a foundation of 4 principles that help establish and maintain a healthy mouth for a lifetime. And while we covered the good bite being a principle of oral health, the next slide will lead us back to Cindy where she covers the rest.
Thanks, Dr. Moralia. And Dr. Moralia has done a great job talking to us about a good bite. So now we're going to just focus on nutrition, home care, and hygiene visits. We've already talked about the oral hygiene challenges when malocclusion is present. As difficult as cleaning misaligned teeth can be, the challenges continue during orthodontic treatment. In addition to that, there may be additional challenges cleaning around orthodontic appliances, for instance, brackets or buttons. You all know that not cleaning properly or not proper cleaning, especially around any kind of orthodontic appliances, can lead to white spot lesions, decalcification, and carious lesions. Really, the last thing that you or your patients want to see at the completion of their orthodontic treatment is decalcification around where their brackets or their buttons were. So it's critically important that you provide your patient with clear directions on how to care for their teeth. In general, of course, but also around any orthodontic appliances that they may have. And still very important to discuss oral hygiene when patients are undergoing clear aligner therapy. And it's also important to recommend specific at-home care items that you've identified using the evidence-based decision-making model as beneficial to biofilm removal and disruption. So first, we'll look at nutrition just a little bit. We all know nutrition is important, not only to make sure you get the right kind of nutrients from a health perspective, but to also avoid foods and beverages that can negatively impact your oral health. This is always important, but even more so during orthodontic treatment. Regardless of what type of orthodontic treatment you recommend, there are nutritional considerations for all of them. So we have some images here of food, if you'll go back, thanks. If we have some images of food that have acidic contact, an acidic level, a low pH, and those pictured foods, if you can really call candy a food, but things that people digest are good to avoid during orthodontic treatment, especially if the patient can't properly clean or neutralize that acid shortly after consuming them. And, we're all familiar with how acidic sodas are, Gatorade type drinks, and citrus juices. Even bottled water can be very acidic. There are some bottled waters that fall into the same category as sodas. So it's not bad just for patients with buttons or brackets, but also our clear aligner patients. We want to advise that they don't put their aligners back in right after having consumed acidic foods or beverages without first cleaning or neutralizing that area. And we also want to discuss with our patients exactly what they are drinking, because they may not be aware that some products, some waters are low in pH. So we want to make sure that we are educating our patients about nutrition in general, but then specifically about low pH beverages that we might consume. Since most literature supports better biofilm removal with power toothbrushes, you may want to consider recommending a power toothbrush or even including one with your treatment. No matter what you recommend, it is important to take the time to demonstrate how to use the device or the product properly. So provide good home care instructions for your patients. There are many resources out there for helping them understand how to clean properly while in ortho or in general. With some power toothbrushes, the apps can really help provide coaching. The apps show people how long they are brushing, and some show if they're missing in any areas, if they're scrubbing too much, or they're pressing too hard. And so this feedback can really help people correct their improper brushing habits. And cleaning interproximal areas is always very important, but really difficult if patients have braces with the brackets and the wires. Before making a specific recommendation, consider what your patient will actually use. It doesn't do any good for the patient or for us if we stay on, you have to floss, you have to floss, you have to floss. If they're not going to do it, then that's not going to work for them. So we want to find something that they will actually use. The right size interdental brushes are easy and effective for removing biofilm from interproximal spaces. Floss picks are easy for cleaning contact areas. And water flosses are easy and very effective for removing or disrupting biofilm in difficult to reach areas. So consider a water flosser that has a nozzle that will cover more surface area than a standard nozzle, because that can be very helpful around braces and even just in general around the gingival margin and interproximal spaces. The more open you are to offering a few options to your patients, the better chance of success that they will use something. And then, of course, there are mouthwashes, mouth rinses that have anti-caries properties. Sodium fluoride is a great one. So that might be something that you would recommend adding to their oral hygiene regimen. If they're really at high risk for caries, then you might want to go a step further and recommend calcium phosphate therapy, because it's used to enhance remineralization. There are commercially available products containing amorphous calcium phosphate, casein phosphopeptide, amorphous calcium phosphate, and calcium sodium phosphosilicate, and tricalcium phosphate. All of those are available. For your extreme risk patients, custom trays should be used to increase contact time. So you might have them wear their calcium phosphate technology for a minimum of 3 minutes of contact time, maybe even longer. And then right after they use it, have them refrain from brushing or rinsing or drinking or eating anything for about a half an hour. And there are also rinses that you can get that a compounding pharmacy might make for you, a just basic sodium phosphate rinse, if that's easier for your patient. But there are some good commercially available calcium phosphate technology products that are available for you to recommend to your patients at high risk. Right, so we all know about prevention, and Benjamin Franklin, a very wise man, said an ounce of prevention is worth a pound of cure. Just kind of to review for all your patients, but of course your patients that are undergoing orthodontic treatment, you may want to have more frequent recall appointments for your patients, just so you can keep on top of everything to make sure they're remaining healthy during their treatment. And then, of course, if you want to provide fluoride treatments in the office, in addition to having them use fluoride at home, if they need that, certainly reviewing their oral hygiene so you can correct the course if necessary. There's some really exciting news in the area of monitoring systems with the Candid Pro clear aligners, and Dr. Moralia is going to share a little bit more information on that.
Yes, thank you, Cindy. So here we're going to be leveraging technology to monitor hygiene during ortho treatment. And so when we take a look at how this works, we'll have this little video play. It's about 20 seconds showing you a patient using our little scan box with their phone and an app on there. And all they're doing is following the instructions in a mirror. to kind of shift side to side. And they have obviously the little tube is like a lip retractor. The app on the phone, it takes a full scan in a matter of 10 seconds. So that 10-second scan, all of a sudden, when you see our next slide, will kind of be in, oh, there you go. It gets uploaded to our doctor portal. So the most fantastic thing about this is that that scan the patient takes, it's done at every aligner. So what you're looking at across the top of the screen is a bar that goes 1 through about 15. So here it kind of counts off the aligners. And at each aligner, the patient takes that 10-second scan. And when it's uploaded, we can track their treatment in our portal. And you can see from the scan, you have a view of the aligner, the teeth, the gum line. And with all of that view, you have an idea with every 2-week interval in the portal, how they're doing. Now, of course, Candid has tracking built into this. If the patient didn't wear their aligner very well, they would be told to wear it 1 more week. So you do get to move on every 2 weeks to a new aligner, provided you wore it well and the scan passes inspection. So the patient takes their scan, and the very first thing that happens is they're told, congratulations, you did a great job. Everything is perfectly tracking. Move on to your next aligner. Or the other opportunity would be that they would take their scan after a rough 2 weeks, let's say, and the response might be, do not advance to your next aligner. All of the movement hasn't been registered yet. Wear your aligner 1 more week, then scan it again. So all of a sudden what happens there is patient wears it again 1 more week, takes another scan, gets approval to move on. That's a typical pattern. And in the course of treatment, if you have a 15 to 20 aligner treatment, it's quite common to have once or twice where you'd see that happen, where the patient would be requested to wear their aligner an extra week to make sure everything stays on track. The advantage is that when you get to the end, you are actually at the end and you don't need additional aligners to finish the job. So when we move on to the next slide, it gives us an opportunity to detect in every category, whether it's the hygiene or the aligner tracking, because the scan with the retractor that's built into using your app, you have a full view of the gum line. So in the hygiene column, you would think about, well, if your patient took a scan and you looked at it on your computer in your portal and you saw like excessive amounts of plaque and bacteria, you have the opportunity to send them a note. You can go right in there and send them a note saying, hey, might want to pick up on the hygiene, get your brushing, your flossing, your rinsing, whatever the agents you are. We're noticing a little bit of the plaque in the picture. We wanted to be a little better, a little more diligent about our hygiene moving forward. Or, of course, you might see in the aligner where, the aligner was a slight misfit. They were asked to wear it 1 more week. Then they were able to move on. You can add a note or tell them that, we've seen this too, wear it an extra week. Or you can leave it and let it go by itself. You're not required to respond. But the good news is you have access. All of a sudden, you have access to be able to share information with your patient and support to make sure their treatment goes as well as possible, and without having them come into the practice. When we see the next slide, all of this is connected through an app. And so you have the ability to see this all in your portal. And we have a support team behind the scenes that gives all non-clinical communications to your patient to make sure the case goes very well. And then, of course, anything that comes into the clinical side of things gets directed to the treating doctor. And then you have the ability to you can text in this portal, you can send the patient a note in the portal, or you can always call them in for a visit. So the opportunity for the monitoring opens up, a variety of things that are available to you, one of which would be a lot more oversight into your patient while they're away from you. And then, of course, the other opportunity would be to reduce the number of visits for treatment. And then that becomes more of a personal preference. So technically, you could reduce this to a beginning and an ending visit, but that's not so much in the relationship style that dentistry, operates. We like to have more of a relationship with the patients. We're looking to establish and keep a good relationship with our patients. So we think about office visits really to do that. So basically, you have the opportunity here to have as many or as few office visits as you would like. And what I usually do is I tailor it to the patient. There are patients who are more than willing to come in every month or two and do clear aligner therapy. But then there are those who have work schedules or home schedules or kids schedules or social schedules that are just make it impossible to get in often. And they might be happier to come in every few months versus every other month. So we do have a few patients who come in rarely, but with the tracking, it doesn't mean I have less oversight. I have the same level of oversight with every single patient, whether they're going to do this in 2 visits or whether they're going to do it in 10 visits. And then our next slide. Brings us to a nice case where we'll just share with you the kind of things that we were talking about all throughout this time frame. So we meet a patient like this, and it represents the average crowded deep bite class 1 malocclusion that comes through your practice. And this could be a patient almost in any dental practice hygiene chair on any given day all around the country. So you have your improper arch form, your improper arch width, your improper buccolingual inclination, the teeth are kind of leaning in, and you have your crowded deep bite. If we brought up our fantastic question, did you have braces as a teenager? We talked about answering yes. If the patient answers yes, then you lead into, well, you probably lost your retainer, and you go right into your conversations about where we're headed. What if the patient said, no, I never had braces as a teenager? Well, look, they're young at 26, the front. The idea here is if that patient answers yes or no to did you have braces as a teenager, you have the opportunity to go into a conversation about the difference between a good bite and a bad bite, teeth being where they belong, coming together appropriately, being more protective than teeth coming together poorly. And then we could see from the next slide where we're headed here, because if we have this patient understand that there's a benefit to having those teeth well aligned in a better bite, we would know from the x-ray that they're a candidate for clear aligner therapy. And then the next photograph or next image would show you the pathway. It would start showing the teeth moving. So our next slide is going to give us movement. So we start recognizing our treatment plan is going to start those teeth. They're going to move along to a better position and then be well aligned with an improvement in the bite. And this shows the anterior view, while our next slide shows the occlusal views, which are nicer. These kind of are nicer for the patient to see that, yeah, look, all of the teeth are going to move a little bit, and then we're going to be well aligned at the end. All of the teeth will take a little bit of a movement, and next thing you know, you're well aligned. And this falls into that class 1 crowded deep bite malocclusion of the less difficult variety. We have the opportunity to fix this pretty much every day in a dental practice. And our next slide is going to show us where we're headed with the tracking, because we can take a look here and see on the top as it kind of works its way across. The numbers from 1 to 16 is the aligner count. And at every stage, the patient takes their scan. And as that bar is kind of sliding across, that purple bar is sliding across, on the left side, the images are changing. So it goes from one to the next. You have all of their scans available. What you notice on the bar is that the numbers are circled in green, and that would indicate that the patient had a successful scan. They were told their tracking is excellent. They should move on to their next aligner. But at number 7, at aligner number 7, after wearing it 2 weeks, the scan told that patient, you should wear that 1 more week. It didn't go perfectly. They wear it 1 more week, they take a scan, and number 7 is then a green circle. And it happened to them at number 9 and number 10. So at 7, 9, and 10, the scan recommended wearing the aligner 1 more week. So at 7, 9, and 10, you added 3 weeks of aligner wear. And then the patient, when they got to 16, they were completed. So having those extra 3 weeks delivered a perfectly tracked case to number 16, no refinement, no additional aligner. If we don't do that and we just go all the way through 2 weeks each to number 16, chances are we're not quite perfect. We might want to order more. Taking records to order more aligners can take 3 weeks to get them back. Now you have the first one in your hand. So the advantage in chair time and time savings is tremendous to just have been guided to maybe wear an aligner or 2, or in this case 3, an extra week. Those 3 weeks don't even add up to the amount of time it takes to get the first or a set of new aligners back. And if you have to wear 3 to 5 aligners to finish the job, you're looking at the 3 weeks of delivery time plus another 3 to 5 aligners, whereas we could be done on time. And the next slide shows the finish. So we were able to take that kind of improper arch form and width and inclination, make a little bit of expansion and shaping of the teeth. So we expand and procline. And when you look at the changes that occur, you get a very nice, simple amount of movement to deliver a beautiful occlusion. And right away, we notice it's the middle photograph that shows us the most dramatic change. Of course, the teeth are straight. Of course, the midline is right. Of course, it looks amazing. The patient used a little whitening product too. And next thing you know, the teeth look good, but never mind the teeth. How about the gum tissue, the gingival remodeling? There's a big difference in the center photograph from the left side of the screen, where you have irregular gum tissue and gingival architecture that is not ideal or perfect, to ideal or perfect gingival architecture. So that's a significant change. You now have a protective occlusion that delivers health and longevity with little to no change over long periods of time, whereas we were talking about that 26-year-old as having changes over time. Well, there's a fair chance at 26 years old, those crowded teeth overlapped in that poor bite, knowing that the gingival architecture is already off, and the tissue is a little swollen and a little puffy and a little bleedy there, all of a sudden has that kind of sharp anatomy and balanced and leveled gingival tissue. And that takes us through a very kind of straightforward class 1 crowded malocclusion, where the advantage to the patient is in every category that we shared with you tonight. And the next slide, I think, brings us to the Q&A.
I can see it. One of the questions is oral hygiene oriented, so I can take that.
Sure.
And what floss pick is used for ortho? So if you just want to clean the contact area, you could use a floss pick like a gum floss pick or a dentic floss pick, something like that. If you're going to floss underneath the brackets, which I don't know about you, but as a dental hygienist in clinical practice, that was not my favorite thing to do. And I'm sure it's not our patient's favorite thing to do. So you'd need a threader if you were going to floss under the wires. But that's where an oral irrigation device, a power flosser, might be really handy to help clean those interproximal spaces really well.
Terrific. I can see a couple of the clinical questions I'll handle for you. This is one of them says, do you have a legitimate app that is good for patients of all ages? So yes, the app can be used at all of the ages that are in treatment. And so what we have is the app is on the phone, and I have been treating teenagers as well. So if you have teenagers, they're very sophisticated and tech savvy. So we don't have trouble with the teenagers. Basically what happens there is the app can be used by teenagers all the way through our older, more experienced patients. I find that in the 60s and 70s, those patients, if they're not tech savvy with apps, their kids or grandkids are. So we would have them, use the app with their kids or grandkids as they see them on a regular basis. And that's been, a very nice thing to do. And people see their grandkids often enough that they can help them with the scan till they get the hang of it. Another question came in to clarify what aligner company is this, and it is Candid Pro. So Candid is the aligner company that we're referencing through this meeting and shared with that example or sample case. So you have Candid Pro is your aligner. Another question says, how do patients maintain this after treatment is completed? Do they end up with a retainer or something? And yes, that is true. When you do Candid aligners, you do end up with a Candid retainer at the end. So you will have your aligners to move the teeth throughout, and then at the end, you get a retainer to then hold it, and the retainers are used at night. So we wear the retainer to bed only when we're done. There's another question. Let's see. What if your patient isn't interested in clear aligner therapy? Yes, there's nothing wrong with that. That does happen because it is not 100% of the time that these conversations are successful. And so all we're doing is we're basically in the education mode, so that the patient understands the things that are going on by what we see and recognize as, wear, tear, chipping, all the things that are deterioration. And then over time, you have an opportunity by giving your patient education and having them understand they have choices. What we find is that there's like percentage of patients who recognize the benefit immediately. The light bulb goes off and they say, oh, I would like to do that. Let's get involved with next steps. Then there's a percentage of patients who will say, all right, well, thank you for that information. I'm going to think it over. And then there are those who will say, oh, I'm not interested right now. The most interesting thing is that over time, what you're doing is you're going to take photographs to follow up. And as you're taking photographs, as the years go by, you have bite wing x-rays being taken, you have photographs being taken. And then, of course, over time, you learn that changes are happening by your photographs. And you might see in a 1 year or 2 year or 3 year interval, I'm noticing more recession, more abfraction, more chipping or wearing of the teeth, and you just share it with your patient. And it gives you a chance to revisit the conversation, because if they go from 35 to 40 years old and you show significant changes in those times, it just gives you an opportunity. So we learn over time that some patients just aren't ready on day one, but it could be a year or 2 or 5 later. And the good news is at any time you handle or treat their malocclusion to a better occlusion, they're better. And it's okay if you could do it at a later date. You still have all of the decades to enjoy a good occlusion. So it's never too late to fix an occlusion, and not every patient's ready on day one. So we just educate and share and then kind of guide them over time so they recognize that things are changing and we could still help. Let's see, can clear aligners expand arch widths? The answer is yes. So clear aligners are excellent at uprighting. The clear aligners are excellent at posterior uprighting, which we use the word expand, but uprighting is probably more accurate. And then, of course, anterior procline. So expand the posterior, procline the anterior, and we deliver all of the teeth where they belong. Clear aligners are an expansive tool. So with Candid, we do use our clear aligners to expand the arches. And the case we showed tonight was a very simple, mild type of malocclusion, but that doesn't mean that's the only place, our technique exists. We can handle very severely crowded and very compromised arch widths with beautiful expansion as well. Let's see here. At what age should you be 35 to 39? Oh, very good question. When we have a lot more time, we get to go deeper into Dr. McNamara's research. 12. It turns out when you're 12 years old and you get to the full set of permanent teeth, 28 teeth and 12 are about coincident. So at around age 12, when you have the full complement of 28 teeth, if you were growing and developing naturally without any intervention, you should be between 35 and 39. That is a range that is tracking for excellent jaw development and excellent tooth placement. If you back up that research, there are other research out there that shows where should you be at 8 and 4. And so it turns out the 4-year-old, if you go back, it precedes Dr. McNamara's research. It's Dr. Bogue's research. Dr. Bogue was the one who showed us that a 4-year-old, and this would be primary teeth, A and J, should already be at 30. So a 4-year-old should be at 30, and then you work your way to 8 and 12 to get to the 35 to 40 range. Let's see, what's your retention protocol for the case? How are you preventing it from relapsing? So it would be obviously the Candid retainer at the end. So it is a clear retainer at the end to wear to bed every night. And we say wear to bed every night forever. So you wear your aligners to treat the case, then you wear your retainer every night forever. It maintains your teeth perfectly positioned where they should be. And let's see, also, were additional aligners done to improve? No, there were no additional aligners made for that case. So I recognize that there might have been a slight discrepancy at the LL2. And if that's an issue, you should make a couple more. So you could make a couple more, but none were made. What you were looking at there was a 16 aligner count, and it delivered exactly those results where both the doctor and the patient were in agreement. We are finished. Let's make a retainer and wrap it up. Is this treatment good for the 3-angle classification? Well, what we were talking about with the treatment would be, well, we're GPs. So what's our comfort level? Because a general dental practice, there are those who do a little bit of orthodontic treatment, and then there are those who do a lot. And so it really would depend on comfort level, education, and experience. So if you're a GP that's taken a ton of ortho and you do a ton of ortho, feel free to use a clear aligner technique like Candid in class 1, 2, or 3. It has all of the applications and all of the auxiliaries do exist. So while we talk about Candid aligners for the case you saw, that was a class 1, a basic case where clear aligners alone, Candid aligners alone could be used. But what about class 2 or 3? Can you use auxiliaries like elastics, buttons, attachments? What about mini implants? Can you go all the way to the nth degree and put in mini implants to use all kinds of interesting attachments and leverage for it? Sure. So there's no end to what you can do with a Candid aligner system combined with auxiliaries. And auxiliaries exist in all of the worlds of ortho, but that just requires more experience. And then, you can choose for yourself where to be. A lot of general dental practices are just very helpful doing aligner alone therapy. So they would be avoiding like class 2 and 3 and more crazy malocclusions because of experience and comfort level. So we don't have to go those ways. Is there a need for any attachments or IPR with Candid? What a great question. So it turns out that I have been using the Candid aligners now for 2 years, and using them for 2 years, I haven't used a single attachment or any IPR. So when we say the word need, not really. Need is the strong word there. You do not need attachments or IPR to move teeth around. So then it becomes a choice and or, a pathway where preferences are involved. And some people prefer to use IPR to straighten the front teeth. That's a particular technique where if you use some IPR, you could straighten the front teeth, and then you're moving the back teeth very little. That doesn't necessarily correct the malocclusion, because when you're thinking about arch form, arch width, and inclination, those are really principles that involve the back teeth too. So if we just use the IPR on the front teeth and make them straight, you end up with straight front teeth but you may still have a narrow arch that has occlusal trauma from the horizontal loading. So we do prefer as a default to not really use much IPR and upright the back teeth and align all of those teeth well without it. It doesn't mean you can't have it. If the doctor prefers to use IPR, it's available. We kind of have a default of using the least amount or none to get the teeth in place. And generally, I don't use attachments. I haven't used them in a couple of years, even predating Candid with previous aligner companies that I had used. I used very few, almost no attachments, anywhere from 1 to 4 attachments in the whole case. And then that you can do a lot of successful tooth movement when you're committed to moving them all. So Candid does have a pathway to do little to no attachments in IPR, which ends up being a bonus because those are the 2 things you would like to evolve out of with a clear aligner technique. It looks like a couple of questions in the hygiene category.
The one about someone is saying that there's a specific type of flosser that they're using, a floss pick, a platypus flosser, so they recommend that. Let's see, other
Terrific.
Yeah, and I think that the QRC was put in the chat. If you couldn't use the QRC, the link was put in the chat. I believe the other 2 are.
Oh yeah, I'm back to that one there. Yeah. If the adults, you can adequately change the arch form. Absolutely. And so, yeah, we routinely correct the arch form, the arch width, and the buccolingual inclination with clear aligners. And so Candid obviously is what I'm using. And for the last 2 years, that's all I've used. You're basically going through your Candid aligners one to the next. Candid aligners are capable of uprighting the posterior segment. So we do move all of the teeth that are present. And when you are diagnosing a malocclusion in the arch form, arch width, and inclination category, you are basically making a diagnosis that says all of the teeth are a little bit out of position. So if that's your diagnosis of having this malocclusion, you have all of the teeth out of position. They all need to move a little bit. So we would be interested in moving all of the teeth to really develop a full and healthy occlusion, as opposed to just straight front teeth, where the back teeth are still leaning in and have improper occlusal trauma forces. Then we have one other question about myofunctional therapy, which is very nice that you asked, when would you do myofunctional therapy with an aligner client? And the idea is that myofunctional therapy, oral facial myofunctional therapy, is a fantastic adjunct to any type of orthodontics, especially clear aligners. So you can use it on all of your patients if you choose. Typically, if you're looking at crowded teeth and a bad bite, there is some level of muscle dysfunction. It could be mild, it could be moderate, it could be severe. And really what that adds up to is that having the muscle dysfunction has contributed to why the teeth are out of position and the bite is bad. While we can mechanically, with our aligners, move the teeth where they belong, the idea is that there isn't stability in delivering teeth to position. And so when you think about the ortho research that was done on relapse, there's a long line of research that was done on relapse to show that completing orthodontic treatment doesn't guarantee stability. Retainers are meant to be worn for life. And that's because relapse happens in the 90 percentile range. So anywhere from mid to high 90s is where relapse kind of occurs. So if you know that most of your patients are going to relapse, you definitely are committed to wearing a retainer every night. The alternative to that is considering if the musculature was dysfunctional and kind of contributed to the poor positioning of the teeth and the bad bite, if you went ahead and moved all the teeth, then doing myofunctional therapy, it retrains the tongues and the lips and the cheeks to behave appropriately. And if they function appropriately, the tongue ends up being the scaffolding for the arch form. And if you go through myofunctional therapy, you could deliver better musculature, and with better musculature comes less relapse. So the relapse rate and or the shifting of the teeth going back is much lower when you have a patient that has proper muscle function and strength. So myofunctional therapy is a tremendous advantage, and I do highly recommend it. One last item tied to that would be the frenum analysis, because in the myofunctional world, you're basically thinking about, well, what if there was a lingual frenum that's a little tighter than it should be? Freeing that with myofunctional therapy becomes like next level, where you can deliver not only the freedom for the tongue, but then, of course, proper, tongue placement for arch form integrity. Thank you very much for your kind attention. Hopefully that scan code got working, and I appreciate everyone's time tonight. Thank you, Cindy. It was awesome.
Thank you, Dr. Moralia.